So I'm going to be talking about using MRI as an objective marker of visceral pain. And I'd like to point out this work is very much a collaboration between the MR Centre at the University of Nottingham and the Nottingham Digestive Diseases Centre. I'd also like to point out I'm a physicist, so I'm slightly out of my depth for some of the things that you might want to ask me about at the end of this talk. So the work we're doing on imaging GI function is really for two purposes. One is for actually looking at the response to food, for understanding factors in the food that influence appetite. And the other is for understanding the way the function of the GI tract is involved in functional digestive diseases. And in both these cases, the gut-brain axis is obviously very important. Visceral sensation and the uptake and the intake of nutrients influence the GI tract and also send responses back to the brain that influence behaviour and cause pain. So the outline of my talk is very straightforward. I'm starting at the top and ending at the bottom. I'm going to look at the esophagus, the stomach, the small bowel, mostly not its structure, but its water content, and the colon. What I'm not going to talk about at all today is the brain, because obviously a lot of other people have talked about the brain, but we're also looking at the interaction between the bowel and the stomach and the brain, both in terms of nutrient intake and functional disorders. So why do we want to use MRI to look at GI physiology? Well, for all applications of MRI, of course, MRI is a high-performance imaging technique. We get volume coverage, we get high spatial resolution, we can collect images quickly, particularly within a breath hold in terms of abdominal imaging. We get excellent versatile soft tissue contrast, and particularly what I'm not going to be talking about today is we can get quantifiable contrast. So we can measure the dilution of meals in the stomach, we can measure the distribution of fat within the stomach and the small bowel, and how the fat is differentially emptied from the stomach. We can look at blood flow and the blood flow responses to feeding. We haven't actually done this in patients, we've only done this in normal healthy volunteers at the moment. And we can look at tissue perfusion in the abdomen. MRI is safe. This allows us to do repeated scans over many periods of time, over a minute, an hour or a day, to allow us to observe dynamic processes. In a sense, this is the advantage and disadvantage of MRI. Dynamic processes in terms of GI function will take hours. So it means, at least at the moment, our studies take hours. But one of our plans, or our sort of current aim really, is to find single time points where we can make measurements that actually characterise conditions, because scanning somebody for 4 or 5 hours isn't really practical. However, the main advantage of MRI is really within an MRI scanner, you can get basically all the other examinations that you can replace all the other examinations that people would normally have to look at GI function. So manometry we can replace, gamma scintigraphy we can replace, and we can also do new things that can't be done with alternative techniques. So whereas a lot of these patients would have had, or do indeed have at the moment, multiple examinations, with MRI you can basically replace all those examinations in one go. And it's straightforward, really. We feed people model meals. The meals are designed to test the system. We feed them to them, they go in the scanner, we scan them, and we often ask about their subjective responses to the meal. So starting at the top, looking at upper GI function, functional dyspepsia is a chronic or recurrent pain in the upper abdomen and the premature feeling of fullness on feeding, and it can be related to gastroesophageal reflux disease, gastritis, peptic ulcer, diabetic gastroparesis. But functional dyspepsia has no known cause and affects about 15% of the population. It often co-occurs with irritable bowel syndrome, and it can be related to stress or to diet. Our aim is really to characterise the condition of these patients and almost prove that their symptoms are real, really. So, first of all, just starting with the esophagus, these are images where basically sort of sagittal coronal images of the person. There's their spine, there's a lung and heart, and this is their esophagus, and this is their stomach. And you can see in this case there's a manometry tube running right down their esophagus into their stomach. And this is a healthy volunteer having eaten a meal that's refluxogenic, so it would have been a fatty meal that doesn't empty very quickly. And you can see very easily periods of reflux in the stomach, now from the stomach into the esophagus. Now, it's true that you can detect this with manometry as well, but in this case, we can do this and look at gastric function at the same time. It's very easy to measure gastric emptying with MRI. You simply draw around the gastric contents. It's been validated many times. We validate it with a balloon, and you get 100% correlation really almost with the MR and the balloon volumes. If you validate it against the gold standard technique for gastric emptying, which is gamma scintigraphy, you get a slight discrepancy, and that's very easily understandable because in gamma scintigraphy you're measuring the volume of the meal. With an MRI you're measuring the volume of the meal and secretions, which is important really because this means we have a handle on the increased secretions. It also means there is probably room for doing both MRI and gamma scintigraphy in a few instances. So in normal healthy volunteers you can see there are very many different gastric emptying curves. So this is how the stomach empties over time. Nutrient meals empty slower because there's feedback loops from your stomach to your brain telling your stomach to, from the small bowel to the brain, slowing down gastric emptying. But also low viscosity meals, which are in pink here, empty faster than high viscosity meals, which are in orange here. And this graph here, speaking as a physicist, this graph here is one of the most amazing bits of data I've ever got in my career. I never really believed to see anything like this. This is the volume of the stomach measured with MRI, so an objective physical measurement. And this is a VAS score, measuring, basically asking subjects how full they feel. And if you ask subjects how full they feel, they score it on a visual analogue score, very much like the pain scores we were hearing about earlier on. And you compare it to their volume of their stomach, they have a linear relationship. There's a linear relationship between the fullness that they report and the volume of the stomach. For a nutrient meal, actually, this curve does fall off for non-nutrient meals, but it's still a very tight relationship. If you go from a low viscosity meal, a thin meal, to a very high viscosity meal, a less pourable meal, there's a change. So a higher viscosity meal, a thicker meal makes you feel fuller, as you might expect. But the question is, how is this perturbed in disease? In patients with diabetic gastroparesis, you get a delayed gastric emptying. In patients with functional dyspepsia, the emptying time is slower, so this is effectively the same data, different ways up. But functional dyspepsia, gastric paresis have delayed gastric emptying. Diarrhea, IBS patients do not have change in gastric emptying. Somebody asked me about serotonin yesterday. This is the effect of 5-HT receptor antagonist on gastric emptying, and you can see that there's a change in the gastric emptying curves for patients with, for normal volunteers with the 5-HT receptor antagonist compared to normal. Gastric accommodation is the way that the fundus of the stomach, which is the sort of storage part of the stomach, relaxes with respect to the meal. So we did an experiment where we gave strong beads within a model meal and weak beads within a model meal to look at the braking forces in the stomach, but we also observed that you get increased gastric accommodation with strong beads, so that in a normal healthy volunteers who've got strong beads, the stomach relaxes in response to these beads. However, in patients with, if you give 5-HT antagonist, you get increased fundal areas. You can distinguish, and I'm not going to talk particularly much about this, but you can distinguish different gastric contents within the stomach, and you can, in this case, see basically a thick porridge meal and orange juice on top. And then becomes very important, you can imagine, to look at the effects of gravity on this gastric emptying, because now you've got layering here, and this is particularly important with fat. You can model the effects of layering very simply by tipping somebody on their right-hand side, because then you put the antrum down with respect to the fundus. This is somebody basically in a coronal section. So standing up, your fundus is above your antrum. If you lie on your right-hand side, the same thing happens. And then you can model the effects of gravity on the meal. And just briefly, if you look at an acid-stable meal, so this is basically a milkshake, which is designed to not cream in the stomach compared to a milkshake that does cream in the stomach. Because of this layering effect, you get very different emptying rates, and you get a half emptying time that is much longer for the acid stable emulsion than for the non-acid stable emulsion. In this case, the liquid phase, the water phase of the meal has emptied faster. Sorry, in this case, in the acid unstable emulsion, the water phase has emptied faster, and so you're now left with the fat being emptied later. Whereas in this case, the fat is emptied early on, and that's blocked gastric emptying. This has profound effects for appetite, subsequent appetite, for the next 4 or 5 hours. You'll feel considerably fuller after this meal. You won't want to eat later on. What we haven't looked at, and what preparing this talk has made me think about, is actually the effects of this in irritable bowel syndrome patients or patients with functional dyspepsia. Because of the changes in accommodation in 5-HT antagonists, I'm pretty sure this would be quite a good test meal in functional dyspepsia. The stomach isn't a still organ, it's in permanent movement. And this is the stomach emptying. It has been speeded up slightly. This would be a very full stomach after, but not only a meal, but fluid. This isn't actually emptying as it appears, it's actually grinding. There's the pylorus here would be closed down, and so if you look at flow rates, which of course you can do with MRI within the antrum, you'll see there's retrograde flow as well as forward flow in here, which is leading to some sort of grinding action in the gastric lumen. From that data, you need to do some sort of data compression because movies of gastric motility aren't very easy to handle. So by various data compression techniques, you can produce images like this, which if you're familiar with ultrasound, are pretty much like M-mode ultrasound scans. This is the distance across the gastric lumen, and this is time. And you can see the lines here correspond to the contractions moving across the stomach, and the angle of these lines here corresponds to the velocity of the contraction, and the frequency of them corresponds to the speed of contraction. So using that, you can then characterise contractions fairly quickly in subjects. This was a case study. What we found is that with different foods in normal healthy subjects, not much changes gastric motility, which is a bit of a shame after you spend a lot of time investing in this software. But in patients with very abnormal gastric function, you get very disordered motility. So this is the control subject. This is the patient with disordered gastric function. So in patients with gastroparesis, you get changed in motility. In patients with celiac disease, you get slight changes in contraction frequency. To get patients with diabetic gastroparesis, you get changes in the amplitude of the contractions. So moving on down to the small bowel, I think it's fair to say the small bowel imaging we do, it's pretty hard to replicate with any other technique. Irritable bowel syndrome is of largely unknown cause. It's either due to spasm in the bowel or disordered perceptions of abdominal sensations related to bowel function. It's precipitated or exacerbated by dietary functions, emotional distress, age, and indeed episodes of bacterial gastroenteritis. So this is a coronal scan through the abdomen. You can see the small bowel here. There's the stomach in a collapsed state, and visceral fat through the small through the abdomen. If we do an image that's sensitive to free water, we get basically an image of just the water here. For the MR people out here, this is a bit more complicated than just free water, but it's the MR free water component. We can do a sort of semi-quantitative automatic quantification technique to measure what we call the free water, the small bowel water content. We validated this by filling the small bowel with various volumes of water, you can see here, and then you get these images of the small bowel water content and a very good agreement between our measured values and the absolute values. Though I do always hold a warning on this data, which is, I think, for certain food contents, this data may not be quite valid. But for the model meals that we're using in patients, it is valid and it is repeatable. So first of all, we looked at the effect of mannitol, which is a laxative, and not surprisingly, it massively increases free water in the small bowel. You can look at the effects of Bram, which has well-known effects on the bowel, and you can see compared to a control meal, if you add Bram to the control meal, you get increased water in the free water in the small bowel, probably due to irritation and effect of the relining of the small bowel, leading to increased secretions. But of course, you can look at the small bowel watering disease. So this is a healthy patient. This is a diarrhea IBS patient. This is a patient with sclerodoma, which is a autoimmune disease. And this is a celiac patient who clearly have abnormal bowel function. So just looking at the moment again at the Bram data and looking at the effect of a meal on the water in the small bowel, if you have a meal, what actually happens after the meal is the water in your small bowel decreases, which was not what we expected. This was an unexpected finding. What we think is, as the meal is ingested, there's a preparation, as you'll see later, of the bowel for the food, and there's an absorption of secretions in the small bowel initially. And then as the liquid phase, in this case the meal empties, the small bowel volume goes up, and then as the meal comes down, it's rapidly diluted in the small bowel. You get a lot of free water and a large plateau. But the interesting thing is here, well, there's an effective Bram, which is the white versus dark measures. There's also effective gender here, with the women, I should say, having higher water compared to the men. What about in IBS? Well, these are IBS patients, a similar curve following a Bram meal. And again, you can see the drop in the water content, but the main thing is you can see there's much higher water content in the normal volunteers compared to the IBS patients. And if you look at their fasting small bowel water, there's a significant decrease in the free water in the small bowel of the IBS patients compared to healthy volunteers. Okay, thanks. And this also relates to the diameter of the small bowel. So there's a sort of general story here. The person who really leads this project, I think, the translational scientist at Nottingham who links the MR and the gut group, is Italian, and he's called it spaghetti bowel. The bowel in IBS patients is very constricted, and there's a smaller diameter, which links to having a smaller water content. Linked to this, in healthy control subjects, if you give a 5-HT antagonist, you find you get an increase in water content in the small bowel. Similarly, if you look at the orocecal transit times, this is transit through the small bowel really, you get a reduced transit time in diarrhea IBS patients compared to controls. And finally, related to that, if you look at the relationship between that orocecal transit time, the small bowel transit time, and a marker of anxiety in the IBS patients, there seems to be a trend for the more anxious patients to have a shorter transit time. So this suggests a relationship between mood and IBS symptoms. We wanted to examine this in more detail. I should really say Robin Spiller, the gastroenterologist, did. So in normal volunteers, he gave corticotrophin-releasing hormone to model stress, and we managed to show that the small bowel water content in the CRH group of normal volunteers, or this is a crossover study, so when you gave CRH, their small bowel water was reduced, very much again like the IBS patients. Finally, colonic imaging is something we're just starting really on, colonic functional imaging. You can separate the volumes of the different parts of the colon and look at how the right and left colon and a transverse colon respond to feeding. On feeding, as I said earlier, the bowel prepares for food to be delivered to it. There's an initial increase in the right colon volume. It's very easy to observe changes in the colonic response to feeding in IBS patients. You see increased volume after feeding in IBS patients. This is sort of ongoing work. The actual colon imaging in IBS is sort of ongoing right at the moment. We can look at the signal intensities and the signal characteristics and the texture, indeed, of the colonic contents with time. And we can look at the motility of the colon with time. So these are movies following a mannitol drink, which is this laxative, and following a glucose drink. You can see much more free water in the colon following the mannitol, and fairly similar, really, patterns of movement within the colon. So one of the problems with colonic motility, and of course colonic motility is important. You can't see that movie, but I can. Oh, well, okay. The colonic motility is important in understanding IBS, but it doesn't happen very frequently. Here you can see a mass movement going through the colon. So what we're trying to use is find an objective test for colonic function by giving movie prep, which is actually a bowel prep material, and using it as basically a stress test on colonic function. And this is colonic motility following movie prep, which makes it much easier to monitor because you can actually see it in real time. We've also used it to look at response to therapies for diarrhea, so loperamide and simethicone are materials given to treat diarrhea. Again, we've used mannitol as a model of diarrhea and looked at the effects of simethicone and loperamide on this, and found that the area under curve, or the volume of the small bowel, is massively reduced if you give these drugs. And the T2, the signal intensity in the colon is reduced if you give these drugs. So, in conclusion, MR provides a means for understanding the physiological basis of dysfunction in the bowel. So is the pain a normal response to a normal function, or a normal response to an abnormal function? Certainly the people we've observed, it's an abnormal function. We can look at the symptoms, we can relate them to behavioural responses, and we can look particularly, I think it's important, at individual responses, with the aim being to give a meaningful explanation to subjects and guide rational treatment. And finally, I'd like to point out this is very much a multidisciplinary project. Robin Spiller's a gastroenterologist involved, there's a whole group of physicists and medics involved, and Luca Marciani is, as we call him, a translational MR scientist, has been key to making this project work. Thank you very much.
Thank you for a very wonderful talk. Anybody, are there questions? Richard?
In veterinary medicine, one has studied fermentation transit time for the last 100 years in ruminants, and one is well aware that it's the microbial colonization that actually determines, at least in ruminants, the transit time. Are you already looking into the gut microflora?
Yeah, that's definitely, that's the reason we're measuring T2s in the gut colon. We're really very keen to look at microflora in the colon and the textures of the colon, to look at the biofilms within the colon. Mm-hmm. Yeah, definitely.
And do you have any outcomes already?
No.
Questions here?
I'm an integrative pain physician. I treat a lot of people with IBS. And just a comment, it was a very interesting talk and gave me some good insight into my patients. I treat IBS with magnesium, either chelated magnesium or the citrate, and find that whether they have diarrhea or constipation, that it normalizes their bowel function and relieves their pain. And so I think you've just given me a mechanism, which is the water content of the bowel when you reach the right dose of magnesium. I thought it was muscle relaxation that I was helping with, and perhaps neurotransmitter formation with increased magnesium as well. But that was very interesting, and I'm wondering if you're looking at that as a treatment modality.
Well, as I say, I'm actually the physicist in this project. We're not looking at that, I know that, but now you've mentioned it, I will talk to my gastroenterologist colleagues about it.